Thank you everyone for inviting me to speak today. Thanks Dr. Hogan, and that was a very entertaining ringer as well. My name is Ananth Thyagarajan. I'm a fellow working in Dr. Wesley Burke's research group at Duke University. I'm going to talk about sort of current management of food allergy. I'm not going to spend that much time on that. This group, from my understanding, is a pretty well-educated group. So then spend the majority of time on sort of what the future holds, both within the research we're doing at Duke, but outside of Duke as well. There's a lot of research and exciting therapies that may be on the horizon. So first, let's go over the goals of today's talk. I want to define food allergy, spend a little bit of time on the diagnosis and current management, provide an overview of the sort of food allergy research world, what's going on, and then describe specific trials that are going on at Duke in the research group that I'm a part of. We'll then finally discuss some common questions about participating in these food allergy trials. So first, again, let's define food allergy. So an adverse food reaction is just sort of this nebulous term for any sort of reaction after you ingest a food. Food allergy is more specific than that. It is presumed to be the result of an immunologically based reaction to that ingested food. And there's a whole spectrum of diseases. The reason you guys are here today is because your family members or you yourselves have IgE-mediated food allergy. IgE is sort of an allergy-driving immune molecule. We'll talk about IgE a lot in the next, over this lecture, so I want to make sure that you guys understand what that is. But there are other food allergy diseases that have some IgE role in them or none whatsoever. But that's not what the research that I'm doing involves. And then there's food intolerance. There are a lot of people with lactase intolerance, for instance, who have an aversion or a reaction to a food, but it's not immunologically based. It comes from a different system. So there are about 8 or 9 common food allergens in the United States. What's interesting is across the world, the food that are the common food allergens are different. What we have an allergy to here is not what is there in Israel, in India, in Europe. Proteins are responsible for the allergies. I was thinking about putting an asterisk there because Dr. Hogan's old mentor, Dr. Thomas Platts-Mills at UVA, is doing some research that sort of points towards certain cohorts of people that have an unusual type of allergy that may be due to carbohydrates. But there's a lot of questions in that research right now. What we do know is that the allergies that we talk about, proteins are responsible for it, so not the fats, not the carbohydrates. And in children, as you all know, the main allergies are milk, egg, peanuts, tree nuts, fish, shellfish, wheat, and soy. The majority of those actually are outgrown by school age. Well, the general rule of thumb is that milk and egg allergy, 80% of kids outgrow it by school age. The vice versa is for peanuts. Only 20% of kids with peanut allergy outgrow it by school age. And in adults, peanuts, tree nuts, fish, and shellfish are the most common. There's also some really unusual cases that we all see as allergists of adults who have eaten fish or shellfish their entire lives. Then all of a sudden they eat it again and they have an allergic reaction. I don't understand why, and if someone does, please tell me, because I don't think any of us understand that. It doesn't really fit with our profile and sort of why these allergic reactions occur, but it does occur. The typical reactions for IgE-mediated food allergy are sort of listed here. The sort of typical symptoms of sneezing, runny nose, hives, but people don't realize that there's also the GI symptoms, nausea, vomiting, abdominal cramps, and diarrhea. Persistent vomiting is a sign of anaphylaxis. Someone eats egg, they're allergic to egg, they vomit once, maybe that's not anaphylaxis. They vomit again an hour later, that is anaphylaxis. That patient needs epinephrine and needs to go to an emergency room. There's always a little gray whenever you talk about this, but I think the GI symptoms sort of get overlooked sometimes. And again, sort of this whole list of non-immunologic adverse food reactions. There's a lot of them. So as clinicians, as physicians, when we have a patient, we have to sort of go through in our heads this differential diagnosis of whether or not the symptoms match what we think is an IgE-mediated allergy, or if it's an allergy at all, or rather is it a food intolerance, a non-immunologic reaction to that food. So next, I'm going to spend a little bit of time on diagnosis and current management. Most important part, we all learn in medical school, whenever someone says, what's the next step, we're all supposed to say history, 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 and physical. But in this case, we're just talking about the history. What is the suspected allergen? What is the food that this person ate that maybe caused a reaction? Was the allergen ingested? Was it inhaled or touched? This is really, really important. If I'm allergic to peanut and peanut touches my skin, I can get a hive from it, but I cannot have fatal anaphylaxis for it. I have to ingest it by my mouth to have anaphylaxis. We have a lot of patients that come in that are afraid of sort of contact allergy, but that contact allergy will not cause a full body reaction. It will cause a reaction only on the skin, and that will not kill you. How much of that food was consumed? Was it a little bit? Was it a lot? It really makes a difference. How reproducible are the symptoms? If you think you're milk allergic, but then after the episode you keep drinking milk every day without having a reaction, that's not IgE-mediated milk allergy. We have to look in a different direction. Does exercise precipitate the symptoms? There is a diagnosis called exercise-induced anaphylaxis. The textbooks patients have wheat allergy. They eat something with wheat, 4 hours later they exercise, and then they have a systemic, full-body anaphylactic reaction. It's an important part of the history that we as allergists need to look at. And then is there an aversion to the suspected allergen? I have a lot of teenagers that I take care of who hate peanut. They're peanut allergic, they won't get near it, and we're trying to give it to them as part of our research, so it becomes a quite difficult situation. Skin prick tests. If you or your family members have ever gone to an allergist, they've probably got skin prick tests. There's two types of skin prick tests. There's the breaking the skin prick test with a little plastic pricker. That's called an epicutaneous. There's also an intradermal skin prick test where it's like a PPD if ever you got tested for tuberculosis, where they actually put the allergen as a bubble under the skin. For food allergy, epicutaneous, breaking the skin prick tests are the only nationally recognized or sort of approved ways of diagnosing food allergy, not the intradermals. It's very useful in the IgE-mediated food allergy, which is why we're all here today. It's highly reproducible, and it has an okay positive predictive value. What does that mean? Well, if someone has a positive skin prick test to peanut, there's about a 50% chance that they're actually allergic to peanut. Where it's really, really useful is its negative value. If someone is negative, has a negative skin prick test, their skin doesn't hive up, that accuracy is greater than 95%. We're 95% sure that they're not allergic to peanut if that skin prick test is negative. Now here's a really, really important point. Larger skin tests correlate with the likelihood of any reaction. It has nothing to do with severity. So someone that has a skin prick test that big versus someone that has a skin prick test that big, the larger skin prick test means there's a higher probability of reaction. But that could be any reaction. It could be a hive on the face. It could be full-blown anaphylaxis. It has nothing to do with severity. So some people think because my child or I have a large skin prick test, I have a very severe allergy. That's not the case. We can't tell that from this test. We actually can't tell that from any test except a food challenge, which actually giving you that food to see how you react. This is probably one of the most important points I want to make today. The other things that we do are blood tests for the IgE molecule that I'm talking about. We want to see how much IgE you have to that particular food, peanut, milk, egg, whatever. Again, it's useful in IgE-mediated food allergy. This represents sensitization. It just means you have it, but it has no correlation with symptoms. It may mean that that leads to symptoms. It may not. Because of that, we really much frown upon sort of shotgun testing. Someone comes in with a reaction, they don't know what it is. Well, let's test for 20 different foods through this blood testing and see what happens. We see a lot of patients that come in with so-called positive blood results for 10 different foods, and so they're not eating anything. They're incredibly restricted. That's not the right way to do things. The way we do things is you take a careful history, those foods you're suspecting, do a skin prick test. If any of them are positive and it matches a clinical history, then you do a blood test for that. There's always a little play in that. You may not always follow that rule, but it's sort of a general kind of practice. And again, just like the skin prick test, just because you have a really large number does not correlate with severity. All it means is probability of any reaction. So we have a lot of patients that we do food challenges on, and I can tell you the most severe food reactions that we've seen have been people that have had IgEs that are actually in the lower range of our total group of patients. We have patients that have IgEs in the 500s, and they'll have one hive on their face. We have patients that have IgEs to peanut, let's say, 10, and they will have full-blown anaphylaxis. So the IgE number has nothing to do with severity, just probability of any reaction, just like the skin prick test. So what do we do with these numbers? Hugh Sampson, he's in Mount Sinai, a bunch of other really fantastic food allergy physicians took all these patients that had suspected allergy, checked their IgE, and did food challenges on them. And then they created these statistical models that gave us a way to predict who had food allergy or not. So depending on, if you look at the top line, if you have a kid who's older than 2 years old, who you suspect food allergy, and they have an IgE to egg greater than 7, that person has a greater than 95% chance of having a reaction. Any reaction. Again, it could be mild, could be severe. We have no idea where in the range it's going to be. And so as allergists, we use this a lot to help determine if someone's allergic or not. So the current standard of care, it's really important to have appropriate diagnosis. Of course, as you all know, strict avoidance of food allergens, which can be really hard. Even with Congress passing the Food Allergy Labeling and Consumer Protection Act in 2004, my nephew has egg allergy, and my sister tells me all the time where she reads the labels and it says, you know, contains wheat, soy, or egg. And even though it doesn't list egg as an ingredient under the contains, if she looks at the actual ingredients, there's something that's egg-based there. So even though we have these laws, are they being followed? I don't know, but something to still be very careful of. Access to treatment, always having a self-injectable epinephrine on you. This becomes really important with teenage and young adolescent kids who aren't in control, are not in the control of their parents anymore. They need to learn from a young age, if they have food allergy, that an epinephrine or EpiPen needs to be on them at all times. One of the things that we've learned is that the sooner that after an anaphylactic reaction the epinephrine is given, the better. And of course, an emergency action plan, something that Dr. Hogan was talking about, and I think it's fantastic they're sort of standardizing it in the area. I think that should be done in all sort of local communities to help schools deal with this ever-growing problem. So mild reactions don't always stay mild. Individuals like you who are part of the Food Allergy and Anaphylaxis Network answered a structured questionnaire about their reactions to peanuts or tree nuts. And as you can see here, the percent of people that had a mild reaction in for the first reaction was lower than in later reactions. So there are people who had mild reactions at first, but then later subsequent reactions, they were severe. So what I hear a lot is, oh, my reaction is not that bad. I just have some itchiness in my throat. So I don't carry around an EpiPen with me. That is absolutely not the right thing to do. You don't know what your next reaction is going to look like. You need to have your EpiPen on you at all times. So now I want to talk about food allergy research that's going on, not in Duke, but in other places. I'll get to what we're doing at Duke later, just to show you sort of where we are in the sort of food allergy world. This is an incredibly busy slide, and the reason I put this in is because each of these different therapies is something that someone is investigating. I put this slide up to show you that there are a lot of investigators, there are a lot of different research avenues being done right now to try to find a treatment for food allergy. We are all working very hard to make this happen, not just at Duke, but in many, many places in the United States and across the world. So first, I want to talk about allergen non-specific therapy. There are many of you who have family members who have multiple food allergies. Wouldn't it be wonderful if there was one therapy that could help with all those food allergies at one time? That's where this comes into play. The two therapies I want to talk about are anti-IgE and Chinese herbal medication. First, the anti-IgE. As I mentioned before, IgE is one of the allergy-driving molecules in the immune system. A study done that was published in 2003 in the New England Journal of Medicine, our sort of gold standard of publications, looked at an older anti-IgE medication, TNX-901. This was a placebo-controlled trial. They took people that had peanut allergy, and they gave them this medication for about 4 months. What they found is that it actually, in the majority of patients, it increased the amount of peanut that they could tolerate from before to after treatment. That's fantastic. There's a big if. There's a big but. 25% of people received no benefit, 0. And there was no baseline characteristics to determine who would get benefit and who wouldn't. So as a physician, am I going to give you a treatment that I'm 75% may work, but that 25% that doesn't work may be a very serious reaction? I wouldn't feel comfortable with that. So that was an older anti-IgE molecule or medicine that isn't made anymore. The newest or latest version is called Xolair, Xolair. It's used presently to treat allergic asthma. A trial done later on, it was a multi-center trial, again placebo-controlled, looking at different doses of this medicine for people who are allergic to peanut. And that 125 milligrams of peanut protein, it's about half a peanut. So they wanted people who, at baseline, reacted to less than half a peanut. Unfortunately, those baseline challenges, at a couple of the centers, they actually had some very severe reactions. So the ethics committee that was looking over the study stopped it because the reactions were so severe. They actually did the right thing. That was what they were supposed to do. The limited data showed a possible increase, but it was very limited because the study was discontinued. And no one's looking at this therapy alone. But I'll tell you a little bit later, a study that I'm doing is looking at this in combination with some other things. So that first study that was in the New England Journal of Medicine took these different doses of the anti-IgE medicine to see before and after if they could tolerate more peanut. As you can see here, this is sort of the mean threshold dose. That's almost half a serving size of peanut. So for the highest amount of this anti-IgE medicine, they actually showed a statistically significant difference. What I find very interesting is even in the placebo group there's a difference. So the people who didn't get anything had a difference. So I'm not sure how to correlate those two things. Traditional Chinese medicine. These are herbal remedies that have been used in Asia for centuries to treat allergies and asthma. It has a favorable safety profile, and at this time there's a low cost. And I kind of laugh and I put a question mark there because as soon as someone puts a patent on it, then the low cost is probably going to go away. But right now it's a low cost. So Mount Sinai in Manhattan is sort of leading the research in this. I feel of all the things we're talking about, this is something I think has maybe the most promise. Again, this is an allergen non-specific therapy. This could be something that you give to someone who has multiple food allergies. It's a mixture of these 9 different Chinese herbs, and they took mice and they made them allergic to peanut. After they treated them with 7 weeks of this Chinese herbal medication or sham or placebo, they found that all the sham-treated mice showed anaphylactic reactions when they were challenged to peanut. But the FAF2, the traditional Chinese herbal medicine-treated mice, did not show anaphylaxis. These are really exciting results. The early human clinical trials are ongoing at Mount Sinai. And this is looking at mice data. So I'm going to try to take you through this, and hopefully I'm not too boring. So these are 3 groups of mice. Naive mice that were never allergic to peanut. These 2 mice were made allergic to peanut, and this mice was treated with the herbal medication. This one was treated with placebo. And then what they do is actually feed peanuts to these mice after the treatment, and they watch them. And there's a little guy with a notepad watching the mouse, and they score these sort of signs and symptoms of anaphylaxis. And the sham-treated mice, the mice who were peanut allergic, who were treated with placebo, had anaphylaxis. But the traditional Chinese herbal medication-treated mice did not have symptoms. And the same thing here. This is a more objective measure. It looks at core temperature, and in mice, when they have anaphylaxis, their core temperature decreases. And in the sham-treated mice, the temperature decreased, but not in the FAF2-treated mice. So that's allergen non-specific therapy. I also want to talk about allergen-specific immunotherapy. So there's 3 things I want to talk about: engineered recombinant proteins, sublingual immunotherapy, which I'm going to call SLIT, and oral immunotherapy, which I'm going to call OIT. And I'll talk about what those are in just a second. So first is engineered recombinant protein. Dr. Burks and Dr. Sampson and some of his colleagues, they, years ago, what they did is they identified the key parts of the peanut protein that caused the allergic reaction, the IgE binding epitopes, in case someone was really interested. What they then did is they took those areas that were causing the allergic reactions and they substituted single amino acids. That reduced the IgE binding, but it didn't change the T cell response. Now the T cells are sort of the general of the immune system. By not changing the T cell response, the hope is by giving this as immunotherapy, you can cause, you can help treat the disease, but not have any of the side effects that come along with giving something that someone is allergic to. So this is one of the proteins in peanut, and the red areas are where the IgE binds to. That's what causes the allergic reaction. And then what they did is they created these single substitutions in those parts. So mice who received this product rectally, the medium and high dose treated mice had reduced anaphylaxis symptom scores when they were challenged up to 10 weeks after treatment was finished. The mouse studies have been so successful that we're starting human studies through COFAR, the Consortium of Food Allergy Research. Now, one caveat to this is the FDA said if you give it rectally to the mice, you got to give it rectally to humans. So this is, I'm not joking, this is a rectally given product at this point. I don't know if it's going to change, but so this one I'm not as excited about. Now I want to talk about two important terms when talking about treating food allergy: desensitization and tolerance. Desensitization is increasing the threshold dose that causes an allergic reaction. And this is a short-term or maybe a prolonged effect with ongoing therapy. This is not quote-unquote a cure. I kind of describe it as like diabetes and insulin. You need insulin to treat diabetes, but you can't ever come off of insulin. You got to always be on it. Desensitization means with ongoing therapy, you have some efficacy, but you have to stay on that therapy. Tolerance is what we're all really, really trying to get to. This is a cure. This is an active adaptation of the immune system. We want to make it so that even after we stop the therapy, the immune system does not react to that protein. So you get treated for 3 or 4 years with this treatment, and then we stop. And all of a sudden, you're cured. You can eat peanut, you don't have to, and you won't have a reaction. Sort of like antibiotics for a bacterial infection. I'll tell you just a synopsis. We've done pretty good work showing that we can maybe do this. This we're still looking at to see if it's possible. So in the allergen-specific immunotherapy, this is sort of the very general way we do things. So we use two forms. Oral immunotherapy, OIT, is either a powdered form of that food, peanut, milk, egg, or we use a liquid form of that food, and we place it under the tongue, sublingual immunotherapy, slit. So we take allergic patients, food allergic patients, and we start them at a really, really low dose. For instance, our peanut studies, we start at like 1/1000th of a peanut. And then that peanut amount is ingested or put under the tongue every single day. Every 2 weeks, they come back to see us, and we slowly increase how much we give them. That's all these little steps here, okay? And then we get to a goal maintenance dose. That's the highest dose we want to get to. In our current versions of our peanut study, the highest dose we get to is about 13 peanuts a day. So we go from 1/1000 to 13 peanuts. So it takes a while, and there's a lot of effort between us and the families to get this done. Once they get to the maintenance, they stay on that for a certain period of time. And each trial has a different length of time. And then we do a food challenge. So then that food challenge measures desensitization. Have we done anything while the patient is on therapy? And then we take them off therapy. We do it for a month. Some places do it for 6 weeks, 2 months. And then we do a final food challenge. And that is to test for tolerance. After we stop the therapy and they continue to avoid that food, have we actually cured the disease? Whatever protection they got here, do they still have it here? That's what we're testing for. All the different food allergy protocols that you see sort of follow this basic format. But each of these phases has many different variables within it. So someone may have 10 doses on this day versus 1. Someone may go up every week instead of every 2 weeks. Someone may stay on maintenance for 3 years, some may stay on 1. So all the different studies that are going on use these different phases are different. So a study out of Europe that came out looking at hazelnut allergy. Hazelnut allergy is a pretty big deal in Europe. It's not a big deal here. They took 23 patients that had hazelnut allergy and treated them with this sublingual, this liquid hazelnut under their tongue. They kept it under their tongue for 2 minutes, and then I think in this one they swallowed. 8 to 12 weeks later, they underwent another food challenge. And what they found is that the patients that actually got the hazelnut slit versus the placebo patients had an increase in the amount that they could ingest, increase in the amount of hazelnut. And this was statistically significant. But almost half of the patients had symptoms consistent to what we called oral allergy syndrome. This is different than traditional food allergy in that some patients eat a food and they have itching in their mouth but nothing else. And it's tied to environmental allergen sensitivity. So I'm not sure if this proves treatment of food allergy or treatment of oral allergy syndrome. Not quite clear yet. But this is one of the sentinel papers on sublingual immunotherapy that we have. And then oral immunotherapy, a powder that you ingest every day. Johns Hopkins and Duke did a study with milk allergy, taking 20 milk allergic patients and randomizing them to receive either milk or placebo. At baseline, they all tolerated really small amounts of milk, 40 milligrams. A cup of milk has 8,500 milligrams of milk protein. So this is a small amount. After the actual treatment, those people in that group had a huge increase in the amount of milk that they could tolerate versus the placebo group that tolerated the same amount. This is evidence of desensitization. They never took these patients off therapy. While they're on therapy, they saw these results, but not of tolerance. They never took them off. So in graphical form, the patients on top receive the therapy, and you can see before and after. Those are median threshold doses. There's a huge difference. In the placebo group, there was no difference between before and after. The patients that were in the placebo group were then offered to start with actual milk powder therapy, and they had their median threshold dose increase greatly after they were offered to start that. And then other investigators are doing things in sort of all these fancy terms. So again, there's a lot of different avenues that food allergy treatment, food allergy therapy research is going on right now. So what's going on at Duke? I know my co-fellow and good friend Dr. Varshney came here last year to tell you what, some of the trials that are ongoing. I want to give you a little bit of an update of those trials as well as some new trials that we've started. Before I get into this, Dr. Burks has about 15 to 20 different studies all at the same time going on in his group. Each one looks at different foods, different maintenance times, different delivery systems. Some of them are looking at the natural history of food allergy, not even looking at treating. So there's a lot going on at our center. So peanut oral immunotherapy, it's peanut flour. So you take this defatted, roasted, dry roasted peanut powder. It's about 50% of protein, and we administer it in a soft food, chocolate pudding, applesauce, whatever the patient will tolerate. The study that is ongoing right now is oral immunotherapy for peanut allergy. It's a double-blinded placebo-controlled trial. So 2/3 of the patients are getting peanut powder, the other third are getting oat flour, and we don't know who's who. The recruitment is complete now, and this has a maintenance dose of 4,000 milligrams of peanut protein. That's 13 peanuts a day. So we have patients that are ingesting 13 peanuts a day once they reach the maintenance phase. The data I'm going to show you fits with these numbers. So with 29 subjects enrolled, 18 were treated through the first food challenge, which happens a year after they start treatment, and after that year they're unblinded. Then we figure out if they're on treatment or on placebo. And those patients that are on placebo are offered to restart the study on peanut. So there's 12 peanut and 6 placebo. So during that unblinding food challenge, what you can see here is that all the patients in the active treatment group, the peanut group, tolerated 5,000 milligrams of peanut protein. Everybody did. You can see the range underneath. There is no range for people in the treatment group. Everyone got to that 5,000 milligrams. It's about half a serving, half a peanut butter and jelly sandwich. The placebo patients had a median threshold dose of 460 milligrams, much lower than they had a range. And there was a statistically significant difference between those two groups. Really exciting results. So this gave us evidence of desensitization. While they're on treatment, there was effectiveness. Now, what about what happens when we take that treatment away? Once we treat it for at least 3 years, what happens? The data I'm going to show you is from an older study, the sort of first generation of this peanut study that was, everyone got peanut powder. There was open label, as we say. It wasn't blinded, it wasn't placebo controlled. We have, in that trial, there were specific criteria for when we could stop the treatment and challenge patients. About 11 people, actually about 11 or 12 people got to that point. Of those 11 people, 9 subjects passed that final food challenge. So they stopped therapy. A month later, after no therapy and avoiding peanut, they came back and they passed that final food challenge. They ingested the full amount. These subjects remain off of daily therapy and ingest peanuts in their diet. That is suggestive of tolerance. Now, I will say, we didn't know what to do with these people afterwards. Like, they asked, well, what do we do now? Should we eat peanut? Should we not? So because we don't know what to do, we tell them to eat peanut. We actually tell them to eat Reese's peanut butter cup once a day. And when would a doctor ever tell a patient to do that, right? But we don't know what will happen once it'll stop. So just to be safe, that's what we tell them. But there were 2 subjects that failed the final food challenge. And there was actually a 3rd subject, who I'm not including, who failed the food challenge even before that. So, and we're not sure how to determine which subjects would pass and which wouldn't. So we've shown some evidence of tolerance in a really, really small group of patients, but we're not there yet. And I also want to point out, and something I didn't put in these slides, is we see a lot of side effects and symptoms. We see a lot, this requires a lot of time and effort from both the physician and the provider, and especially from the families. This treatment is not ready for prime time use because of all the side effects and symptoms that we do see. We see some pretty bad reactions. And because we know what we're doing, we're trained to treat these reactions, we feel comfortable with it. This is only ready for the research world. This is not ready yet for widespread clinical use. So a study that I'm in charge of, that I'm excited about, is looking at the peanut powder treatment as well as the anti-IgE, the medication I talked to you about before. Like I just said, there are a lot of side effects and symptoms associated with the peanut oral immunotherapy, especially during the buildup. So what if we add anti-IgE before we start the treatment and during that buildup time? Maybe we can get rid of those side effects and symptoms. So in this trial, for 4 months before they start the peanut powder, we take older kids with peanut allergy and treat them with Xolair anti-IgE. This is a very early trial, so there's no placebo control, and we're having a goal enrollment of 10 subjects. All the people have to be greater than 10 years of age because the FDA only approves Xolair for people who are 12 years old or greater. We do food challenges the day we stop oral immunotherapy, years down the line, 2 or 3 years, as well as a month later. And this trial we're actively recruiting for. So just to take you through this a little bit, at enrollment, everyone gets the anti-IgE for 4 months. It's a shot. It can be 1 shot, it can be 3 shots. It all depends on the patient's baseline weight and some baseline blood values that they have. After that 4 months, we start with the build-up phase. We try to go for, and since we've given this anti-IgE medication beforehand, we try to go from day 1 to the end of day 2, from 1/1000th of a peanut all the way to half a peanut in a 2-day span. That's a goal. We haven't gotten there with everybody, but that's a goal we're trying to do. During the build-up phase, where we're going from that half a peanut to 13 peanuts a day, takes about 5 months, best case scenario. And we continue the anti-IgE the whole time during that treatment. And once they get to maintenance, we stop the anti-IgE and they continue for 1 or 2 years. Then we have the food challenges at the end. Again, this is an early clinical trial, and that's why there's so few patients that we're recruiting. And the Xolair medication is really, 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 really expensive. So then another study that we're starting and actively recruiting for is looking at peanut oral immunotherapy in younger patients. Mucosal immunotherapy for peanut allergy in young children. There's actually an acronym that the guy who created this study, it's called the DEVIL study, DEVIL. I can never remember what it stands for, but we are Duke, the Duke Blue Devils. And studies that have acronyms, as you know, for some reason get more play in the world than studies that don't. I never understood that. But this one has an acronym. So we're taking really young kids, 9 to 36-month-old kids. And whether or not they're eligible depends on different criteria, and that criteria depends on whether or not they've actually had a clinical reaction. There are a lot of patients that have reaction to egg. We bring them in, do some testing, and find out they're maybe peanut allergic too, but they've never ingested it. My nephew's one of those kids. Those patients will have a different sort of criteria than patients that have actually had a reaction. These are young kids, 9 months, 36 months, and they're randomized to receive 2 different doses, either 300 milligrams or 3,000 milligrams of peanut powder. Part of what we're testing here is there an immunologic window? Is there a window of time where we can do the greatest good with the least negative side effects? I don't know. That's what we're testing here. It's actively recruiting. This is a big trial, trying to get 120 patients. I think they probably have like 15 or 20. So we're slowly increasing the amount that we can get. Tree nut oral immunotherapy. This is sort of the next generation. A lot of people that have multiple tree nut allergies. We want to take those people and treat them if they have walnut allergy and let's say almond allergy. We want to treat them with walnut oral immunotherapy, walnut powder, and see if it suppresses not only the walnut reaction but also the almond reaction. In mouse models, we've actually shown this. We take mice, make them allergic to walnut and almond, treat them with walnut immunotherapy, and their reactions to both those tree nuts are suppressed after treatment. So since we see that in mouse models, now we're starting early human trials. This is going to be tough because there are going to be multiple food challenges in the beginning to all those different tree nuts. Every time we do a food challenge, that's a significant risk. So that is something that people who participate are going to have to think about before participating. This is a collaboration between Duke and the University of Arkansas, where Dr. Hogan and Dr. Burks used to be. And the recruitment should begin in the fall. We have to get the protocol through our institutional review boards and things of that sort. But hopefully it starts recruiting soon. Peanut slit. So taking peanut liquid, pumping it through that little bottle under someone's tongue, holding it for a couple of minutes, and then what we do is we swallow in Duke. Some places spit it out. The thought is that theoretically that the peanut protein gets absorbed by the capillaries under the tongue, kind of like nitroglycerin. When someone has a heart attack, they put it under their tongue and that medicine gets absorbed pretty quickly. So a study looking at, it's a blinded study looking at peanut slit in children. 1 to 11-year-old peanut allergic kids, they have 40 subjects. They stay on the maintenance peanut slit for 2 years. You can see here this 2 milligrams is a lot different than the 3,000 milligrams of maintenance dose in the peanut oral immunotherapy. But it's a different route of delivery. So the amount that you give really depends on the route of delivery. So we're hoping that that's enough to actually cause effectiveness. The recruitment is complete. I put an asterisk by that because I think there's going to be a next generation of this study coming out in the next 4 or 5 months. So this is an area of where there could be more recruitment happening soon. And this is a Duke-only study. And then basically the same study looking at adolescents and adults with peanut allergy, looking at peanut slit in this population. Again, 40 subjects, slightly different maintenance dose for 3 years, not 2 years. This is a multi-center trial in that consortium of food allergy research, which encompasses these universities' medical centers. The recruitment for that is complete. And then the other study that I'm a part of is a study that we're doing in conjunction with Johns Hopkins, looking at milk allergic patients and giving them both starting them, everybody with milk slit, and then 2/3 of the patients then switch over to oral immunotherapy, and the other 1/3 stays on slit. There are a lot of food challenges during this study. We have all the subjects are recruited that we planned for. I'm going to show you some preliminary results that were presented at our last allergy meeting in New Orleans at the end of February. So looking at the amount of milk these patients could tolerate before and after treatment, both the slit and the OIT had increased amounts of milk that they could tolerate after therapy. This, although it is less than this, was significantly different than what they reacted to at baseline. And what this slide doesn't show you is, so both are effective. One looks like it's more effective. What this slide doesn't show you, though, is that the people who had slit had a lot fewer side effects, a lot fewer symptoms than the oral immunotherapy, the milk powder kids. So if you think about something that's going to be used in the mainstream, if you can show some level of desensitization while on treatment and the minimal negative side effects, that might be what's more useful mainstream than something that may show more effectiveness but can be more dangerous. And then finally, there's a peanut patch coming out, of all things. So there's a company in Europe that's devised this patch where they electrospray peanut powder and protein onto this patch. They've done mouse studies, and they've been pretty successful, according to them. So they've gone through the Consortium of Food Allergy Research, and they want to start early clinical human trials. These are purely safety trials. These aren't looking at effectiveness. There's 4 different doses of this peanut patch that is going to be put on for either 1 or 2 days, then replaced for over a 2-week period. During that 2-week period, all the patients are going to get EKGs, blood draws, things of that sort to make sure that they tolerate this therapy. If it's shown to be safe, the next trial will be looking at effectiveness. But how wonderful would this be if this was actually a treatment, a patch to treat food allergy? I don't know if it's going to work, but it could. Finally, I want to talk about sort of common questions about participation in food allergy trials. If any of you were here last year, my colleague, Dr. Varshney, went over this, but it's really important, so I wanted to go over it again. Are there benefits to being in a research study? Of course, but there may be no benefit to you in being part of a research study. The benefits are global in that you help food allergy research in general, and you help the lives of other people as well as of yourself, possibly. In general, you have a lot of opportunities to learn about food allergy. We see our patients for 2 to 3 hours every 2 weeks. We get to know them really, really well. And we have discussions all the time about food allergy, myths, truths, and I think our patients are so well educated after treatment and before treatment. And I think it's one of the great benefits of being part of the research group. During the study, the patients will have physical exams, lung function testing, as well as other things. And then there's the study-related medical care, as well as medicines are provided at no cost. There's an asterisk there because Duke has a policy where any research-related injuries, so you have a reaction at home to one of your home doses, you have to go to the ER, stay in the hospital overnight, your insurance or you are responsible for those costs. It's a pretty important point when thinking about joining one of our research studies. Most important thing is that food allergy research is a partnership. We spend a lot of time together. The researchers and the patients and their families, again, this is really a partnership. We can't do this without each other. Safety is our top priority. We will never hesitate to pull someone from a study or to stop a study if we think their safety is in danger or if they are in danger. We talk about this all the time. We are giving something that you are allergic to you. Safety is number 1. And communication is key. We want to know what's going on with you and your family while this therapy is going on. It could be very important in sort of the overall scheme of things, as well as individually for you. There are applications, but these are investigational therapies. They may not work for everybody. And there's a lot of studies have placebo arms. So if you're in a placebo arm, you're not actually getting the treatment that we're investigating. And we do acknowledge that there's a lot of time and effort taken by the families to do participate. We also consider developmental level of the patient. There's a lot of lab draws, skin prick testing, IV placement. If your child isn't ready for that, this may not be the right for them. We also want open communication between the study staff and the families, and we really want parents, families, patients that adhere to the protocols. If someone doesn't take their peanut dose for 5 days and then all of a sudden takes it again, they might have a really bad reaction. So right now we're enrolling subjects that are within a 2 to 3 hour driving distance from Duke. The main reason we do that is because if there is a reaction to a home dose, we don't want them to be too far away. There is currently a waiting list. We do have a screening database, but I'll talk about that in just a second. It's not as well-oiled machine as it should be. There's no financial compensation for participation, but we do give you parking vouchers so that you don't have to pay for parking. So we're hopeful that in the next 5 to 10 years there'll be a treatment available mainstream for food allergy. And I think the most important thing for people who want to follow this, go to clinicaltrials.gov. This is one of the other really important things I can tell you. type in food allergy or peanut allergy in search, or milk allergy, whatever you're looking for, and you can see the trials that are going on, not just at Duke, but across the country. We're required to put trials in there if we want to publish the results. One of the things we found is simple economic supply and demand. We only have very limited resources, but the demand for this therapy, this investigational therapy, is high. So if you're interested, call. If you don't hear back, or call again after 6 months. Be nice. That always helps. But check clinicaltrials.gov, search Dr. Burks, search food allergy, search peanut allergy, and you can see what's going on across the country. There's a lot of people to acknowledge, but especially want to thank Dr. Burks. I am not as smart as him. He is seriously a genius, and he's helped me out so much over my fellowship, and there's a lot of people that are involved in this research. And I want to thank you all for inviting me here, and see if you have any questions. Thank you. For everything but the younger patient study, the one between 9 and 36 months, there has to be a clinical history of reaction, yes. Sure, a great concern. Your allergist is yeah, so I'm going to talk about the 2 points here. One, your allergist is a good allergist and is doing the right thing. This is not ready to be done in sort of the mainstream widespread use. There are a lot of side effects, a lot of things we don't understand that need to be straightened out before this is done on a regular basis. In fact, Dr. Burks and I we just submitted an editorial to the Journal of Allergy and Clinical Immunology talking to that effect. Second, each trial has different criteria for inclusion or not inclusion. So you have to sort of call to see if your child would fit into any of the inclusion criteria, because they're all different in terms of the peanut IgE numbers as well as everything else. Sure. Yeah. So allergies across the board, hay fever, food allergy, it's been increasing in westernized countries for the past 60 years. No one knows why. There's a lot of theories. Are we too clean? Is it vaccines? Vaccines cause everything, right? We don't know. My wife thinks it's because she's a big Michael Pollan fan, Omnivore's Dilemma. So she thinks it's all the additives that we have. Who knows? I have no idea. We don't know, but we do know it is increasing. There is some evidence, though, in Canada and the UK of stabilization of allergic disease. Instead of it increasing anymore, it's kind of like plateauing. Small studies, but some hope. But we really don't know. You can have allergies to some of the things in your environment, but we haven't shown that they've been tied together. Like you're allergic to dust, that means you're then allergic to something else. We haven't tied those together. All they indicate is probability of reaction. What percent of people who have that number are going to react to the food? And that reaction, again, could be mild or it could be really severe. Just the probability. That's it. I will say, you want to see that number decrease over time. And once it gets below, most allergists use 2 as a cutoff value for milk, egg, and peanut. then you have about a 50% chance of not reacting. So most allergists will say once those numbers get below 2, we'll challenge you. We'll give you that food to see, in a controlled setting, to see if you're not allergic to it anymore. Sure. That's a really great question. So we've seen side effects ranging from allergic reactions, which you expect, but some of those allergic reactions can be really severe. We've also seen reactions that are sort of vague, just sort of this abdominal pain, vomiting, that doesn't fit with the timing of the dosing, but once we take the dosing away, the vomiting goes away. And then once we give it back, the vomiting comes back. We don't know what that is. That's one of the things we're really worried about in terms of making this, whether or not this is ready for the mainstream use. Mm-hmm. So a couple of things about this study. It's biased, right? So you send a questionnaire out to all these people who are part of a food allergy group, and not everyone sends it back. Only certain people. So maybe the people who've had subsequent severe reactions are the only ones that send the survey back. You have no idea. But what we do know is one reaction does not predict the next. It could be, one reaction could be severe and the next one could be less severe. We have no idea, or could be the other way around. But there is some bias built into that study. It does not necessarily mean that, and but you should have a healthy fear of that. Of African, yeah, obviously, yeah, yeah. Don't try to give it to my home.
And another point just to make too, a lot of allergies feel that there may be a dose response.
Absolutely.
So that one time there may be a severe reaction, but it may be because you ate too peanuts, and the next time the reaction might be severe, but maybe the just is only half peanut. So when we look at severity of reactions, the one factor we don't know is how much do they actually get. And certainly the amount that's injected can affect the severity of the injection. And the thing is that oftentimes, you probably have heard this stuff too, is the late reaction that can happen with food allergies. And we know that with peanut and peanut reactions, a third of the time there's a second wave or a late phase reaction that can happen with those particular ones. And again, that may not be dependent upon the severity or the amount of jet used. So that's another factor that's thrown in there. So much like you may have relaxed one time, but the next time it wasn't severe, maybe this one time is a late phase response, and the other time is not. All of that sort of thrown in there, and gone through on the what to predict, essentially, we can then take, you've heard it's so very important to have the everything, not just thorough.
And two very good points. EpiPens, multiple pens. A lot of times it takes a while to get to emergency care, and the EpiPens really only last for like 30 minutes. They're a Band-Aid, they're not a cure. So if the reaction comes back after the EpiPen wears off, or if one EpiPen is not enough, you gotta give a second one. And the late phase reaction, we know really little about it, honestly. We know there's like 2 studies that look at this. So general rule of thumb, we say it happens within 4 hours. And so in emergency care, we hope that emergency physicians will, if someone comes in and says they have a food allergy reaction, but they look okay right now, we hope that they will be observed for at least 4 hours before they get sent home. Time. There's no, and support, yeah, medical support and time. With whatever symptom they're having, treat that symptom. If there's wheezing, give them breathing medication. If there's problems with their blood pressure, give them fluid to help their blood pressure. Whatever symptom is having, you want to treat that symptom, and time hopefully will make those symptoms go away. That's tough. Steroids are very controversial. I actually am not a big believer in them because we don't have any data saying that steroids do anything. Supposedly they prevent that late phase reaction that we're talking about, but unless I'm wrong, Dr. Hogan, there's no objective evidence saying that steroids do this. So I actually don't give steroids. Yeah. Wow. Yeah.
Certainly not 3 or 4 or 5 days.
Yes.
Our common ER pattern areas.
And do too.
They're crazy to death,
Yep.
give them a drug steroids.
Yep.
Things that they have, saved their life.
And Duke too, even our emergency physicians do the same thing. But I haven't seen any evidence that shows that it works. Support. Get to a emergency medical center, care somewhere. Mhm. Yeah, so there are a lot of people that have dermatographism, which means you just scratch their skin and it kind of blows up. So what allergists do is we actually do a negative control. We do one of those prickers that has a little bit of peanut in it, and then we do another pricker that just has saline, a sterile, safe liquid. And we subtract how big the saline hive is from the peanut hive. And that number is what we use to determine if it's positive or negative. A number of 18, I will say, a skin prick test greater than, I think it's 9 or 10, has a 90% chance of reacting on food challenge when you give that person the food. So if they said, you know what, that skin prick test is too large for us to do a food challenge, I actually agree with that. I would have done the same thing. No, again, you had that negative control. You would kind of treat it the same way as someone who did not have eczema. Sure. Not that I'm aware of, but I know there's a lot of sort of news in the media as well as looking at sort of global inflammation and how that affects us and these different systems in our body. I'm not aware of anyone looking at sort of global inflammation specifically talking about food allergy. I'm not aware of it, but it may be going on. That's exactly what you do. So we follow our patients every year with IgE testing to that specific food plus or minus skin prick testing. And I would strongly encourage you to have your daughter see someone who has experience with food allergy or has been trained in it, like Dr. Hogan. It makes a lot of difference. It really makes a difference to have experience in this. I wouldn't try to do surgery on your ear because I have no experience in it. So I'll just put it at that. Yeah, so that's the one study that I'm in charge of. Because we're giving that anti-IgE medicine beforehand, we're hoping we can decrease any allergic response that's happening. But I will say, we're very early in the study, and we've had one patient to get to that point, and he did not get even close to half a peanut. He got to like a third of a peanut. He was like 5 or 6 doses below it before we stopped because he was having some reactions. So we don't know if this is going to work or not. It's research. A lot of it depends on the clinical history. If it's someone who actually had a reaction to a food, then if that food skin prick test is positive, that gives you a higher sort of post-test probability that that test was accurate. If it's a kid that has sort of weird reactions, you don't know what's going on, then you test for a bunch of things, that's the scenario where I'm not so sure how great the positive values are for those tests. And in terms of repeated testing, the tests are highly reproducible. If someone's positive one day, it should be positive the next day. But over a year's time, it may be different. I would suggest, depending on your family's the history, to ask, why are we testing for all these different things? It may not be necessary. National Jewish, wonderful allergy and immunology pulmonary hospital in Denver, actually did this phenomenal study where they took kids who were avoiding like 10 or 12 different foods. And then they did food challenge to all these kids. And almost all of them, they got them down to like 3 foods that they had to avoid instead of 12. Imagine the difference it made in these families' lives to be able to do that. So we have to be careful with some of the testing that we do. We have a concept called pre-test probability and post-test probability. Before we do a test, from 0 to 100, we think the patient may have a 10% chance of the disease. Well, the test being positive or negative gives us an endpoint for the post-test probability. So that 10% then becomes maybe a 40% chance. But if that pre-test probability is 80% and then you do the test, then you have a higher post-test probability. So not trying to be confusing, but the clinical history really has to drive the testing in most patients, in all patients. Great question. The can of worms, right? So the American Academy of Pediatrics statement in 2008 was very, very different than the statement they made in 2002? I forgot that was last year. 2000, sorry. So they changed everything. What they said was that exclusive breastfeeding for 4 months, as well as delaying the introduction of solid foods to 4 months, you can then decrease the chance of eczema, early wheezing, and cow's milk allergy in the first 2 years of life. Anything else, we have no idea what we're talking about. Say it again. So there is also another caveat to that. If for that first 4 months in children that have a parental history of asthma or a sibling history of allergy, patients that can't be breastfed exclusively, using partially hydrolyzed formulas showed some efficacy in preventing those same 3 things. But those 3 things are limited. We're talking about eczema, wheezing in the first 2 years of life, and cow's milk allergy. Has nothing to say about peanut allergy, egg allergy, wheezing after 2 years of life. We don't know anything beyond that. So when my son was born, my wife asked him what to do. I told her, if you want, you can breastfeed exclusively for 4 months. And it was really, really hard for her, and she did it. But I also told her that we don't know. There's a lot of studies going on looking at, well, maybe we should be introducing peanut at an early age. Dr. Gideon Lack in the UK is actually testing this hypothesis. He's taking kids that have a higher probability of one day having peanut allergy, and he's giving them peanut starting at 6 months. And then he's taking another group and not giving them peanut. They're going to follow these kids for 5 years and see who develops peanut allergy and who doesn't. The results will come out in 2012 or something like that. But depending on that could change everything we say. So it's an ever-changing world, but right now, exclusive breastfeeding for 4 months, delaying solid foods until they're 4 months of age, has been shown to decrease eczema, wheezing in early life, and cow's milk allergy in early life. That's it. Ah. Yes. No, don't refrain from anything. You're a mother, you're pregnant, eat what you can. Get calories. The old recommendations say mothers should avoid peanut, fish, blah, blah, blah. There's been evidence, mainly out of Europe, that says that's wrong. You don't have to do that. My wife ate a peanut butter and jelly sandwich every day, and she was so worried about it while she was pregnant. But I told her it's the only thing you can eat. Eat. Get calories. Calories is so much more important for the growing fetus than anything else. So go ahead and eat what you want.
What's the recommendation if there's already a peanut allergic sibling? There's a new baby arriving. You instruct the family in different, they already have gotten peanut allergy.
I wouldn't. At this point, I just don't see the evidence there that says, oh, remove peanut from the home. Oh, the mother shouldn't be eating peanut.
What about the baby?
About whether to give peanut or not?
Yes, you would have to give them like a
After 6 months of age, I would. Yep. Which is, I don't know if that's the right thing to do because we don't have the data to show that. But there is some data coming out of Canada, I think, who does show that siblings of people with peanut allergy have a higher chance of having peanut allergy. But it's such a small set of people, I'm not totally convinced. So I could be wrong in what I say, but it's what I tell people. I'd have to talk to Dr. Birch about that because he owns some of the data, but I can talk to him about that. Oh gosh, that's a good question. I have no idea. I have no clue. That's a great question. You just look at the back and it has protein amount, and so in general, about 8 grams of protein is a serving. It's like a peanut butter and jelly sandwich. That's a great question. I should really know that. And I don't. I'm sorry. So the LEAP study in London, like I talked about, giving peanut early, L-E-A-P, you can actually Google that, LEAP study. That's what I know of. I'm sure there's a lot of other studies going on that I'm not aware of. But that's one of the really major ones. When those findings come out, Dr. Hogan and I will both be there in the front row, along with everybody else in the allergy community, to see what they say. I mean, they're testing. Each study tests, has maybe one or two hypotheses that you can test. You can't test everything. So these other theories I don't know if people are testing them. I'm not aware of it, but I'm sure some of them are. I'm just not aware of it. So lactose intolerance is very much different than food allergy. So there's no research that I'm aware of that ties those two things together. Ear infections and things like that, I mean, I can see scenarios where someone has chronic ingestion of a food that they're allergic to that may cause swelling or inflammation in sort of that system that could cause blockage of fluid that should be leaving the ear, leading to ear infections. But I'm just really kind of pulling this out of the air. I haven't shown any research that really ties those two things together.
I have a comment too, about the introduction to the LEAP study. We're all very much hoping they will shine the light and tell us if we see them early or we don't see them early. But if you follow the stuff that's out there all the time, it all depends on who the population is and what the
Yeah.
food is too. In the last year or so, we saw one study where it said, okay, in Norwegian children, if you feed them fish early, then they'll have, and early meaning like 6 months of life. I don't know what 6 months old is there. But anyway, if you feed them fish early, they'll have less allergies. And then there was a study about a year and a half ago that said, oh, it's very important to get immunity weak.
Yeah.
If you introduce week between 5 and 7 months, that may be the wrong time to introduce week. And then, there was another study that said, oh, no, you should introduce week a little bit earlier. It's all very confusing. And that's probably part of the reason why the American Academy of Pediatrics said, we don't know anything.
Dr. Hogan's correct. I mean, there was a study that came out even last month in pediatrics, which is another well-read journal amongst pediatricians, that looked at, said, oh, delayed introduction of foods led to less sensitization to those different foods, but the study really wasn't well done. I'm actually upset that it was put in pediatrics. I don't know why they did it. But we have so much conflicting evidence for both sides of these issues, for all these issues, that it becomes hard to kind of filter out what's really relevant and to find out what's right to do. Wow. No idea. No, yeah, and that's one of the things you learn in textbook. You have to have some exposure. We've always thought the exposure comes through breast milk, and if you avoided that, I don't know. I have no idea. Mm-hmm. So again, yeah, it doesn't correlate with severity, but I would say anecdotally, the people that have, when you first find out, have lower levels, they have a less distance to go to get to below that 2 number. So I would say anecdotally, you know, there is, if you have a higher level, it's a less for chance of outgrowing it. But that's anecdotally. It's not based on really any objective data.
And there are more and more case studies presented in our national knowledge and stuff. You know, with how we had IgE at 75, 2 months without breaking that one. So we had a child who was presented with an IgE at 45. And I told him, I don't think we'll ever outgrow it. Now he's sitting there in my work. I mean, he was over the book for about 5 or 6 years. So every time everything died and came down. And that means it's below 2, and that's what we found. So I think there are less of those stories. However, it may be partly because of the point out we weren't looking for those stories. And as time goes on and we follow it a little more clearly, we may find more. But there are anecdotal stories of people that didn't have an outgrow it with high numbers of the probability.
Again, anecdotally, don't have objective evidence on that. No, they're totally different. Yeah, so the list I showed you up there is the best list that we have, but there's a lot of foods, like basically every other food that's not on that list. Wheat we have a little bit of data on, soy we have some data on, not great, but really peanut, egg, milk we have good data on. All these other foods that people are allergic to, we don't know what these IgE numbers mean. We don't know what % probability of IgE of 14 to banana means. We have no clue. So it's a really good point. The list that I showed you is the standard list that we use for sort of those 3 food allergens. But there's a lot that we don't know about IgEs to other foods. There is some for shellfish. I think it's like 20 is a 95% chance of reacting. But that number is, again, not as well documented as it is for peanut, egg, and milk.
And then the last year, there's been some data published for sesame as well.
Yep. And sesame seed is actually an allergen that has increasing implications in food allergy in this country over the last maybe 10 years. And so a lot of people come in and say, I've eaten hamburgers my whole life, and then I ate a hamburger again, and I reacted, but it's actually the sesame seeds on the bone. I mean, we don't know, but I would say if you've had that many anaphylactic reactions, you know, be careful. You know, yeah. You know, in that specific scenario, you really got to be careful. And I don't know what's going to happen. I honestly don't. I don't think anyone does. Yeah, yeah. So they're available in these publications. I don't know them off the top of my head, but if you look up F8HF2, FAF2, that acronym, F8HF2, but I would be very careful to not just mix them up yourself and start giving them to your daughter. Again, yeah, those are on the list, sure. But Google that and you could find publications that have that and list them out. But you know, there's specific proportions of these herbals together. I don't know that level of detail about the formulation. No, that's not for maintenance. That's the one where they're ingesting a certain level of peanut powder as maintenance, but at the very end of the study, after we showed that even off therapy, they were able to tolerate peanuts, that now that they're kind of done with the study, we've asked them to continue eating Reese's peanut butter cups. So they have some peanut. Some of them are. A lot of them hate peanut with just a passion. It's something they've avoided their whole lives, and then we've given it to them every day. This peanut powder has an incredible smell to it. And it's really, if you don't like it, it's really tough to eat. So even getting these kids to eat the Reese's peanut butter cups is tough. They just don't want to do it. They hate it. So some of them do eat other foods, but a lot of them don't. Not because they can't, because they don't want to. It doesn't do, not that we know of, it doesn't do anything. We don't have data showing that external ingestions prolong or decrease at the length of the allergy. So mast cells and basophils are kind of the soldiers of allergic reactions. They're the ones that release all these chemicals that that cause these reactions. Histamine is one of like 10 different chemicals that are released. So antihistamines help against that, but they don't help with the other ones. So antihistamines are good for mild reactions, but if you're given epinephrine, you can go ahead and give Benadryl or some sort of other antihistamine, but it's really the epinephrine that's going to do the most good in that scenario. That is a fantastic question. I'm so glad you brought that up. No. And that's a synopsis answer. So for kids, no. Kids are healthy. Their hearts work well. Whoops. So give them epinephrine. We always tell our patients, if you're thinking about it, go ahead and give it. Older patients who are on beta blockers or a certain kind of heart medicine or blood pressure medicine or arrhythmia medicine, or who have like bad hearts, those are patients you need to be careful of. But kids who have healthy hearts, go ahead and give it. It's not going to do any harm. Yeah. 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 Yeah, I'm not going to give you an answer now. I'll deal with the second question. No, not that I'm aware of people who have heavier food allergies. I've seen a couple kids who have such severe food, who were told they had such severe food allergies that were avoiding like 20 different foods that were nutritionally compromised, but they really weren't allergic to all those different foods. But true food allergy epidemics, I haven't seen any data showing that they're smaller. First question about what to do with your 1-year-old. I don't know. I really don't. If they're allergic to potato, I would recommend avoiding potato because again, you don't know what the next day is going to, the next reaction is going to be. I know it's not the answer you want to hear. Oh, maximum. Oh yeah. So is she eating potato now? He is, sorry, he is. And how's the eczema doing? Good and bad, comes up and down. Yeah. I mean, if you found a difference with the eczema while they were off potato and while they're on the, and you just rather just put the potato and deal with the eczema, I think it's okay, just be careful. You don't know what's going to happen. I don't know the answer to that because that really, there's no evidence of what you're doing. I honestly, I don't. I know. I'm so sorry. I wish I could tell you an answer, but yeah, I know. My sister said to me, my nephew has egg allergy, and she tells me all the time, "Just lie to me." I'm like, I'm not going to lie to you. I don't know. I'm sorry. Sorry. All right. Well, thank you very much.